into reform, and what we'll be experiencing is there's a bit of, you know, our board of directors is a little worried. You don't know what population is going to actually become your member as we go through this enrollment period towards the end of the year. So with an unknown population, what the federal government has said is we will provide you, any carrier that goes into this, with the 3 R's, and they all relate to a risk issue. One is a reinsurance possibility. The most important one is a risk adjustment process, which will mimic what's going on the Medicare Advantage side. So we're a little concerned that, okay, if we, and again, this is a net sum zero mathematical game. In other words, if you attract a sicker population and therefore would need additional dollars from the pool that is generated, somebody else is putting the money in, because that's a net zero at the state level. So we believe that we just want to make sure that our practices are well versed in appropriately coding, so if we do attract a population of consumer that is using services more appropriately, that we are compensated appropriately based on their diagnosis. So part of that educational process we'll be doing over the summer is that it's important to have that happen. And we're going to be funding primary care practices that want to work with us on identifying those patients, building those teams that include primary care, specialty care. Behavioral health is a huge issue. I'll answer that one right now. We are not carving out behavioral health. We are carving it in. We feel that we have a very broad base of psychiatrists throughout the state that are part of the IPA that came forward in our network. We are now contracting with behavioralists, social workers, PhDs, et cetera, to build out a network that you'll have access to when you need behavioral health services. Some primary care practices have gone even further, and they started to hire their own behavioralists, which I think is fabulous. I think it's an area that does need attention. So I'm getting a little cut off here, though. Anyway, so we're going to be rolling this new plan. So again, just as of yesterday, we were an insurance company before, but we weren't licensed. As of yesterday, we were licensed. We'll be bringing this to you. Watch for additional information. We're going to get this stuff out to you. We see you all as small businesses also that might want to have your employees as part of this. So please take advantage of that if you get an opportunity to do so.
Thank you, Ken. If anyone has any questions, we'll take questions about this new insurance company. Yeah,
you talked about incentivification and on a basis of outcome based on per member per month. You also referenced PCMH. Now, using the NCQA guidelines, if you reach tier 2 or 3 and you are a contracting entity at the table, will your insurance company recognize the contracting party aside from the PMPM for deliverable of patient-centered medical homes? Will there be an incentivification for that? Will there be some sort of recognition for that?
For the entity?
For the contract, is it the hospital contracting or the PHO that's contracting?
If a PHO came forward to us and said, this is our structure, here's our legal, these are our physicians that have applied, we would have to work with that PHO on what your relationship is with the physician to do that. Right now, if a physician is contracted through us independently, then that's the relationship that we'd have to honor from a contractual point of view. If they come to Health ECT through the PHO, then the arrangement's done through this PHO, and the PHO has its relationship with the physician on how those dollars are used.
But are you willing as an insurance entity, as an insurance company, to incentivize for the deliverable of